to the audience. So my name is Ashwin and I'm a house surgeon at AIMS. Today I'm going to be talking about mitral regurgitation. We had a woman, 56-year-old lady, come in with complaints of breathlessness that started 3 months back, fatigue that started 3 months back, and palpitations that started 3 months back.
Okay.
A 56-year-old female from Tamil Nadu presented with complaints of breathlessness that was insidious in onset that started 3 months ago. Initially, she used to get fatigued only on ordinary physical activity, but it gradually progressed to fatigue at even less than normal activity and was relieved only by rest.
Here you can tell about NYHA classification. What will be the NYHA classification here?
So over here in the NYHA classification, initially she was just having NYHA grade 2, but then she progressed to NYHA grade 3 and
Only on ordinary physical
activity.
Ordinary physical examination, physical activity is grade 3.
Grade 3.
Grade 1 is unaccustomed work.
Unaccustomed.
Other one is second one is grade accustomed work.
Accustomed.
Grade 3 is ordinary physical activity. Grade 4 is at rest.
At rest. So then fatigue that started with breathlessness 3 months back.
So we should never confuse this as grade 1. Only on ordinary physical activity is a grade 3.
Grade 3.
Unaccustomed work is when you are walking, daily you are walking for 1 hour. And if you are walking more than 1 hour, you are getting breathlessness, that is unaccustomed work. If it is within 1 hour, then it is accustomed. If it is routine work like ordinary physical activity, it is grade 3.
Yes, sir.
Okay.
Fatigue that started with breathlessness 3 months back, acute in onset, and gradually progressed with activity being aggravating factor and rest relieving it.
Okay.
Patient noticed gradually increasing palpitations for the past 3 months with even normal physical activity that gets relieved a short while after taking adequate rest.
Okay.
She had no history of hoarseness of voice, syncope, or hemoptysis.
All these things where it come hoarseness of voice in a cardiac disease. Why it is like that?
So there's a syndrome called Ortner syndrome, where there is enlargement of the left atrium, and it will press on the left recurrent laryngeal nerve.
Okay. Syncope is due to?
Syncope is mainly due to decrease hypotension. Hypotension and decreased cardiac output.
A fixed cardiac output,
Yes,
like aortic stenosis, subaortic stenosis, HOCM and all.
Yes, sir.
But even then, syncope can be due to conditions where, like you told, it can be due to reduced cardiac output.
Yes.
Hemoptysis?
Hemoptysis, it happens in pulmonary when there is pulmonary edema.
Okay.
The patient can start because of the increased pressure. Patient can start coughing out little blood. Sputum. Past history, patient was diagnosed to have rheumatic heart disease as a teenager, but she started treatment but did not complete her treatment, nor did she do any follow-up.
Okay.
And she has no history of diabetes mellitus, dyslipidemia, or systemic hypertension.
Okay.
Coming to the general examination, pulse was 93 beats per minute. It was irregular, and it was a high volume pulse.
Okay. So what is the importance of irregular pulse and BP recording?
So in this patient, if we see the pulse was irregular, so we had measured for 1 complete per minute, and irregular pulse is most common in a condition called atrial fibrillation.
That's okay. I am asking a relationship between BP and irregular pulse. Atrial fibrillation, how to record the BP, that is very important. At least 3 times you have to record, because every beat the BP is different.
Yes, sir.
It's a varying output state. So you have to record multiple times, or you continuously monitor the patient. So one reading of BP will not be sufficient in patients with atrial fibrillation. You have to take at least 3 readings. That is very important. Okay.
Yes, sir.
High volume pulse, where will you get?
So high volume pulse, we get it in mitral regurgitation.
Okay. Mitral regurgitation and
aortic regurgitation.
But when you have a irregular pulse, what happens to this volume? High volume can be there, but it will be varying. That you have to mention.
Yes.
Every beat it is irregular. Every beat the output is different.
Yes, sir.
So high volume is okay, but that itself is varying. So varying volume, but it is high volume.
Yes.
How do you know that it is high volume?
So high volume
BP.
BP is having
high systolic BP and low diastolic BP. Okay, that mostly it will tell you that there is a high volume pulse, or you can simply by feeling the pulse itself, you can feel it is high volume.
Yes.
Okay, what is water hammer pulse?
So water hammer pulse is most common in aortic
AR,
regurgitation.
AR. Okay. There, when you ask the patient to lift the hand and you are feeling the pulse, and suddenly pulse collapses, and next beat will be more powerful. That is water hammer. Like water hammer, it goes down, then suddenly it
comes
increases.
up in power.
Okay.
And saturation was 98%, respiratory rate was 16 per minute, and she was afebrile.
Afebrile. Yeah.
Pallor was not present, icterus was not present, clumping and cyanosis was not present, but bilateral pitting edema was present in the patient. Sir.
What it indicates? This is only positive finding here. It indicates what in a cardiac case?
So it indicates right ventricular failure.
It indicates ventricular failure, more of right ventricular character. Left ventricular failure ultimately lead to right ventricular failure. That it can produce all these findings. Or right ventricular failure as such can produce all these things.
Yes, sir. And lymphadenopathy was absent. Now coming to the systemic examination of the cardiovascular system.
Okay.
On inspection, the jugular venous pulse was elevated in the patient.
Okay.
And the shape of the chest and spine looked bilaterally symmetrical. Epigastric pulsations were present.
Okay.
Apical impulse was seen in the left sixth intercostal space lateral to the midclavicular line. Shape of the precordium, it was very hyperdynamic.
So you see all these things. JVP is elevated due to what?
So JVP is elevated mainly due to the the severe back pressure.
RV is enlarged or RA is enlarged. That pressure is into the jugular vein. Okay, so that indicates, in this case, it indicates a volume overload. Okay, shape of the chest spine is symmetrical.
Yes, sir.
Epigastric and suprasternal pulsations are there. That indicates what? Epigastric pulsation means what?
Epigastric pulsations indicate an enlarged right ventricle.
Okay,
Sir.
so that here it is due to enlarged right ventricle. Okay, apical impulse is totally shifted out and down. So this is a normal heart. Here it is shifted out and down. That indicates what?
That indicates left ventricular hypertrophy.
It is not hypertrophy, it is dilatation. It's a volume overload condition. Whereas in hypertrophy means what? Hypertrophy and dilatation, what is the difference? Hypertrophy is something like this. So the chamber is reduced in hypertrophy, whereas the whole ventricle is enlarged in dilatation.
Yes.
Okay. Hypertrophy means only muscles are thickened. Okay. Yes, now, the inner part of the ventricle, that is a cavity, is reduced. Whereas other one, cavity is increased. It's like balloon. Okay. So left ventricle, sixth intercostal space, and shifted lateral. That indicates a volume overloaded condition. What are the volume overloaded conditions?
So volume overloaded conditions in a patient with CKD stage 5.
No, volume overload condition, heart valve disease.
So valve disease, AR is
AR, MR. These are the two important things. Then VSD. AR, MR, VSD. Other than that, it can be anemia, thyrotoxicosis, beriberi, so many conditions. Okay, then you told about hyperdynamic precordium. Yes. That means what?
So hyperdynamic precordium, in the sense the precordium is, it looks very, the movement in the precordium
starts bulging.
Yes.
Okay. So that indicates a volume overload situation. Okay. Go to next.
Now coming to palpation, the apex beat was felt in the left 6 intercostal space, 2 cm lateral to midclavicular line. It was forceful and hyperdynamic on placing the finger.
So what do you mean by apical impulse?
So apical impulse is something that is seen, and apex beat is something is what we palpate.
Okay. So what is that? It is the outermost and lateralmost definitive cardiac impulse. Okay. It has to be definitive. So sometimes you can see lot of pulsation over the chest. They are not apical impulse. It is the outermost and lateralmost definitive cardiac impulse. Normally it is in the fifth intercostal space, medial to midclavicular line. But conditions like this, it is already shifted.
Yes, sir.
Okay.
Then there was left parasternal heave was palpable.
That indicates what?
That indicates right ventricular hypertrophy.
Okay, so in the parasternal sternum is this, you keep your hand like this. Okay, keep your hand like this on that part, it will be lifted up and down.
Yes.
Okay, so that indicates left ventricular parasternal heave. That will coincide with the apical impulse. If it is before apical impulse, then it is a left atrial parasternal heave. That's the difference between left atrial and left ventricle. Left ventricle parasyn, he will be always with the apical impulse. Left ventricle, right ventricle beats same time.
Yes, sir.
Whereas it occurs before that, then it is a left atrial parasternal heave.
Yes, sir.
Okay.
And epigastric pulsations were palpable, and there was a systolic thrill present.
Thrill
as well.
indicates what? What do you mean by a thrill?
So thrill is a palpable murmur.
Palpable murmur. So it shows there is a definitive cardiac problem there. Only thing is sometimes you can get innocent murmurs, flow murmurs, all these things, thrill will not be there. There is a definitive cardiac lesion, thrill is there. Okay. So thrill indicates a definitive cardiac lesion.
Yes.
Okay.
Now coming to percussion and auscultation, in percussion, S1 is soft, S2 is...
Percussion, you don't get S1. Percussion, you percuss the
auscultation.
cardiac borders.
Cardiac borders.
Most of the cardiac borders corresponds to your apical impulse and sternal border. Okay, that's all. Because there is no much importance for percussion in cardiac examination. But traditionally, we learned that percussion has to be done. Left border has to correspond to the apical impulse. Right border has to correspond to the sternal border. Okay. And so S1 is soft. Where will you get S1 soft?
So if S1 is soft in in valve disease, because the position of the valves will be...
Okay. So MR means that this is a left ventricle and this is the mitral valve. Normally it has to approximate like this. So that produces the sound. Okay. That produces the first heart sound. Okay. If that is not approximated properly, like this is a valve orifice and valve cusps are like this. If there is a leak here, this will not touch each other. So that will not produce S1.
Yes,
okay.
sir.
So S1 is soft means mitral valve regurgitation is there.
Regurgitation.
Okay. Whereas in mitral stenosis, S1 is loud.
Loud.
Okay. They open with a sound, close with a sound. In mitral stenosis, here there is no approximation, so there is no sound.
Yes.
Okay.
And S2 is widely split with P2 being loud.
That indicates what?
That indicates that the aortic valve is closing much earlier, and P2 is loud basically because patient might be having pulmonary hypertension.
Okay, so that most important is P2. P2 will be auscultated in pulmonary area. A2 will be auscultated in the aortic area.
Yes.
But it is very difficult for an MBBS doctor to make out all these things. But even then, if you are getting a loud S2 in the pulmonary area, that indicates pulmonary hypertension. Okay.
And a murmur was present, which was apical pansystolic murmur that was high pitched and blowing, radiating to the entire precordium and best heard with the diaphragm of the cells.
Okay. Okay. So that means you have, so normally S1, S2.
Yes, sir.
Okay. This is S2. Okay. Normally it is like that, no? S2. What you are hearing is you are not getting S1. It is faint.
Yes, sir.
And you get a pansystolic murmur. Okay, S2 is loud. A2 is okay. T2 is loud. Okay. So this is the event you are seeing here. Okay, correct, no?
Yes, sir.
So you are not getting S1. You get loud P2. You get a pansystolic murmur. Okay. So that is especially seen in the mitral area. So you are getting a murmur in the mitral area.
Yes, sir.
Correct, no?
Yes, sir.
And now you have to tell whether it radiates to the axilla or radiating to the base. Where it is radiating?
So it was radiating, I could feel like precordium whole.
Okay, whole precordium is there, but then both the cusps are involved. If it is radiating posteriorly, then anterior mitral valve is involved, just opposite of that. Anterior mitral leaflet is involved. If it is going towards the base, then posterior mitral leaflet is involved. Both sides it is radiating means both valves are involved, both cusps are involved.
Yes, sir.
Okay. Okay. So this is the ECG what you are seeing here.
So in this ECG, I can note that in some leads there is absence of P wave.
Okay. So more than that, for an MBBS doctor, you have already told that irregular pulse. So what pulse is seen in ECG as QRS complex. Every pulse will produce a QRS complex. So this is one pulse, this is one pulse, this is one pulse, this is one pulse, like that. But they are varying. Okay. Irregular QRS complex, and you are not seeing P wave. That indicates atrial fibrillation. So this ECG shows he is having atrial fibrillation. Okay. Any condition which left atrium is enlarged, it can produce Atrial fibrillation, MS, MR, all these things. Okay, so this is atrial fibrillation. Okay, next. X-ray shows what?
So X-ray shows increased. It shows pulmonary edema. So because increased.
So a lot of
obesity.
infiltrations are there.
Yes, sir.
Everywhere infiltrations are there. So mostly it is pulmonary edema. Heart is slightly enlarged. So it is mostly pulmonary edema. What are the differential diagnoses for this? So if this patient come with 2 weeks history of fever and you are getting an history X-ray like this, it can be viral pneumonia, it can be tuberculosis, it can be ARDS, it can be so many things. Okay, so here you have a valvular, you are suspecting a valvular lesion, that is leaky valvular lesion. Patient is having fluid overloaded condition with X-ray shows cardiomegaly and bilateral infiltrates. Mostly it is pulmonary. Okay. Then
so in pulmonary edema, so there'll be like 3 grades.
Okay.
For pulmonary edema. Grade 1 is cephalization.
Okay. Cephalization means top you get lot of infiltration.
Infiltration, yes, sir.
Then
So in grade 2, we'll see the curly A and curly
so
B lines.
you may get lines here this side like these lines. Here also you may get curly B lines. Okay, they all small fissure edema. Okay. Then
And grade 3 will be bat wing.
bat wing means it will be like this.
Yes.
I'll just show you. So it will be like this. Bat wing will be something like this. So here you can see lot of edema is there.
Yes.
That will expand to this side. Okay. So bat wing edema is last stage. Okay. This patient is having pulmonary edema. Okay.
Yes, sir.
Okay. Now what is your diagnosis? Ultimately you have to tell the diagnosis, no?
So diagnosis, we can diagnose the patient.
So what is your final diagnosis? This patient is having
mitral regurgitation.
This patient is having mitral regurgitation. Okay, MR is your diagnosis. Then
with most.
But you have to grade the MR. How do you grade the MR? What are the things which you can tell it the severity?
So murmur, thrill and cardiomegaly.
Okay.
And whether S3.
So if S3 is there, then there is definitive cardiac failure. The clinically, if S3 is there and cardiomegaly is there, you have already seen cardiomegaly, there is pulmonary edema. S3 you are not hearing, but sometimes it may be there. We don't know. Okay. So then that indicates severe MR. Okay. So this patient is having moderate to severe MR with pulmonary edema. Okay. If it is associated with MS, how do you know that it is MS? Some patients can have MS MR. How do you diagnose MS and MR together? So
MS and MR, in MS we might even hear that opening snap.
Opening snap may be there then.
Then in coinciding with that, we might even hear an extra mid-diastolic.
Mid-diastolic. So normally in mitral regurgitation, S1 is soft and you get a pan-systolic murmur. Okay, pan-systolic murmur. So this is pan-systolic murmur. You get S2 is heard here and you may get an opening snap in the diastolic area and you get a murmur in the diastolic phase. Okay, MDM can be there. Okay, what are the other causes for MDM in MR? If MDM is seen in MR? MDM is seen in MR?
In MR,
normally MDM, an MBBS student learned that MDM is seen in MS. Okay. But here what you are seeing is the left ventricle is already dilated. It contains large amount of volume. Okay. So it has to pump through the aorta. Okay. That much blood may not go to the aorta and it is going to the it is going to the left atrium. That is producing your pan-systolic murmur. But this much blood has gone back to the left atrium and left atrium is also receiving other things also. Okay, left atrium is receiving blood from the pulmonary area also. Okay, so what happens to the volume of left atrium? Volume has increased. So next cycle that also sends lot of blood to the left ventricle. That produces a mid-diastolic murmur. This is a flow murmur. So a flow murmur in the mitral regurgitation case, that indicates severe cardiac lesion. So what are the severity indexes? One is you have enlarged heart, hyperdynamic circulation, all these things. Second thing is you have an S3. Third thing is a mid-diastolic murmur. So these three things will help you to make a diagnosis of severity of the lesion. How do you manage this case? So
Emma,
what is the first problem you have to address? One is she is having pulmonary edema.
Yes.
You have to relieve the edema. How do you relieve?
So for relieving pulmonary edema, we can start diuretics like
So you give Lasix, then you give BiPAP or CPAP or NIV. It is called as NIV, non-invasive ventilation. So you should remember that our alveoli is there. Alveoli now lot of edema is there in this patient. Okay, your alveoli lot of edema is there. So oxygen diffusion will not occur. So you are putting a pressurized air into this by NIV. So what happened to this fluid? Fluid will displaced, okay, outside. So this will contain, again air will come back. And some alveoli in your body is collapsed. They are called as dead space. These collapsed alveoli will open. Okay. So that is the mechanism of NIV. So any patient who is having breathlessness, propped up position, oxygen, NIV, then Lasix. Okay. Second problem is what in this patient?
So second problem in this patient, the valve.
Second problem is atrial fibrillation. Atrial fibrillation with fast ventricular rate. Fast ventricular rate. Okay. So what is the problem of fast ventricular rate?
So fast ventricular rate, it can lead to ventricular fibrillation, which is a very...
No. It is not like that. See, suppose your heart is beating like this very fast. What will happen to your diastolic phase? It will come down. Your diastolic phase will come down. If your ventricle is not getting adequate blood during diastolic phase, the pumping also will be reduced. Okay. And atrial fibrillation itself will reduce the ejection of blood from the atrium to ventricle. So both the things reduces the ventricular inflow and it reduces the cardiac output. So what you have to do? You have to control the rate.
Ventricular rate.
Okay, so that ventricle will get adequate time to fill the ventricle. So what drug you can use there?
So amiodarone.
Amiodarone can be used, but that is not the first line drug. You can use beta blocker. And use calcium channel blocker. Only thing, calcium channel blocker should not be used in a failing heart. Beta blocker can be used if it is only atrial fibrillation producing the failure. Okay, if you already failed heart, we should not try. So this patient, we have started amiodarone and heart rate is controlled. Okay, so the second problem is either beta blocker, calcium channel blocker or amiodarone. Depending on the clinical scenario, you can use. Since this patient is having heart failure, we started amiodarone. Or if the patient is in shock, we have to go for shock. Okay, so that can be done. And valve, what we'll do?
So for the valve, so we can do procedure of mitral valve replacement.
Okay. Here, since there is regurgitation, we can only replace the valve. If it is stenosis, we can dilate the valve. Here, we can only go for mitral valve replacement. Once you replace, what all things you have to take care? You have to give anticoagulants for a longer time or lifelong, depending on the valve type. Okay, that's the main thing. Okay.
Yes, sir.
So anything else you want to add?
Thank you so much, sir, for the opportunity.
Okay, thank you.